Hi, I'm Sophie from In the Mess, and today we're going to talk about hypernatraemia. Sodium is one of the most important electrolytes in the body, and many biological processes depend on sodium for proper functioning. Sodium is used to maintain electrochemical gradients through the sodium-potassium ATP pump and is the ion involved in propagating action potentials in the nerve. It makes up a large proportion of serum osmolarity and is a signal for thirst, renal autoregulation, and hormone release. As such, it's closely regulated in normality, but when homeostatic mechanisms start to break down in illness, abnormal sodium can be an important finding. The important thing to remember is that sodium is inextricably linked to water. Where sodium goes, water will follow, and vice versa. So when considering abnormal sodium, remember to think about the patient's fluid status. High sodium levels are mostly seen in patients who are frail or vulnerable due to dehydration. For example, patients in the ICU who are unable to eat or drink due to sedation, babies or small children, and elderly multimorbid patients. These patients usually look and feel thirsty. This is the reason why bars give you free peanuts. It makes you buy many more drinks. As levels rise, patients may become tired, confused, develop twitches, or even seizures. Assessment. Assess your patient's fluid status. Check your patients are getting fluids in. Are they drinking? And if not, are they getting appropriate volumes of maintenance fluids? For more on this, see our fluids video. Do your patients look dry? Patients with intracranial pathology, such as subarachnoid hemorrhage, tumours, or post-operative patients, may have impaired osmoreceptors in their hypothalamus, so they may not feel thirsty. People with dementia may need prompting, and you should discuss with the nurses whether your patient needs assistance with meals or fluids to make sure that they get this. Check for fluid losses that may not have been replaced. Patients with burns may have high insensible losses, and people who have been persistently pyrexial or sweaty may be quite behind with their fluid intake. Look for vomiting, diarrhea, and check the drain output. Make sure that your patient is passing urine and look at how much. You'll probably need to ask the nurses to record fluid status on an input-output chart to get a full idea of this. Get a urine sample and send it for osmolality and sodium. Your patient should be producing concentrated urine and be trying to excrete sodium. If they're producing lots of dilute urine, they may have diabetes insipidus. Consider their medications. Diuretics can aggressively drive fluid loss and quickly lead to dehydration. If your patient is getting lots of IV medications, such as antibiotics, check with the nurses whether these can be made up in glucose solutions or water for injections instead of 0.9% saline to reduce the amount of sodium you're giving them. If patients are on lithium, this can also cause nephrogenic diabetes insipidus, and this is a great thing to pick up. Management. If you can identify a cause, try to correct it. For example, reducing diuretic doses or replacing fluid loss. Calculating the water deficit may be helpful, and there are online calculators for this, but here is some general advice. For patients who are shocked, a systolic blood pressure of less than 90 or a rising lactate greater than 2, resuscitate with isotonic crystalloid solutions such as 0.9% saline, Plasmolite, or Hartmann's to restore normal circulating volume. For patients who are hemodynamically stable but dehydrated, encourage oral fluid intake as tolerated, as this is the most physiologically normal mechanism. If IV fluid replacement is required, for example, lots of ongoing losses, your patient's nil by mouth, or unconscious, then use hypotonic maintenance solutions such as 0.18% sodium chloride with 4% glucose and 0.3% potassium chloride if available. Patients who are fluid overloaded with hypernatremia will be really complex to manage and may need dialysis to restore their sodium and water balance. Discuss these patients with your registrar early, as they may need critical care or renal input. It's important to regularly monitor U&Es and fluid status to make sure your patients are improving on your chosen treatment. Remember to look for a cause, check your patient's fluid status, and ensure they have adequate fluid replacement. Don't forget to like and subscribe so you never miss a thing.